Okay, so this is going to be my CNA lectures for chapter 41 and 42. We're going to start off here with pressure injuries. Looking into pressure injuries, before defining them, you need to understand these terms. So, a bony prominence. A bony prominence is going to be an area where the bone sticks out or projects from the flat surface of the body. A shear. A shear is when layers of the skin rub together and when the skin remains in place with the underlying tissues move and stretch and tear. So the last lecture, chapter 40, we talked about a lot of skin tears and wounds and healings. So a shear is going to be part of that. The only thing with a shear is it does tear the underlying capillaries and the blood vessels. Friction. Friction is defined as the rubbing of one surface against another. Pressure injuries are defined as the National Pressure Ulcer Advisory Panel defines them as a localized injury to the skin or to the underlying tissue, usually over a bony prominence. The Centers for Medicare and Medicaid says that it's any lesion caused by an unrelieved pressure that results in damage to underlying tissues. Skin color and change remain after the pressure is relieved. Patients with light skin will see a reddened bony area. Patients with dark skin, the skin color may differ from the surrounding area. The skin may feel warm or cool, and the patient may complain of pain, burning, tingling, or itching in the area. Risk factors for pressure injuries are going to be pressure, okay, the main thing. Other risk factors include breaks in the skin, poor circulation to an area, moisture, dry skin, irritation by urine and feces. Also, if the skin and tissues die, if friction scrapes the skin, causing an open area. Also, if there's a poor blood supply or an infection that can lead to these injuries. And then lastly, when a patient has that shearing thing happen and the patient slides down in a bed or chair where the blood vessels and tissues are damaged and the blood flow to the area is then reduced. So this slide right here, this is slide 7 on your CNA lecture if you're following along with me. Stage 1 is going to be the lightest stage and then goes all the way up to the worst stage of a pressure injury, which goes all the way through all 4 of those skin layers is going to be the worst. So stage 1 is the most minor, stage 4 being the worst. Stage 1 pressure injury, the pigment gives color to the skin. The skin is intact with a localized area of non-blanchable edema arrhythmia. So arrhythmia is redness, which may appear differently in the darkly pigmented skin. There's also presence of blanchable arrhythmia or changes in sensation, temperature, or firmness of the skin. Stage 2 pressure injury. These are partial thickness, loss of skin with exposed dermis layer. The wound bed is viable, pink or red, moist, and may also present as an intact or ruptured serum-filled blister. The adipose or fat tissue is not visible, and the deeper tissues are not visible either. This stage should not be used to describe moisture-associated skin damage, including incontinence, associated dermatitis, trigonous dermatitis, medical adhesive-related skin injury, or traumatic wounds. A stage 3 pressure injury, so we're going to the worst injuries as we go along here, is going to be a full thickness loss of skin with this pressure injury. It is going into where the fat is visible, and there's granulation tissue or rolled round wound edges are often present with these. There is slough or eschar may be visible. Eschar may look a little bit brownish black in color as well. The depth of this tissue damage varies by anatomical location, so where it's located within the body. The fascia, muscle, tendon, ligament, and cartilage are not exposed though, so you can guess what stage 4 is going to be, where that bone, the fascia, the muscle tissue are going to actually be exposed. Excuse me. So these 4 pictures here are pretty rough to see, but I need you to see the sloughing off example and then the eschar is going to be this blackish picture over here. So pretty rough. If you can't see these slides during my presentation, then you might just flip through the presentation after you get done watching my recording. An unstageable pressure injury is going to be where there's full thickness skin and tissue loss, in which the extent the tissue damage with the ulcer cannot be confirmed because it is insecure. If the slough or eschar is removed in stage 3 or 4, the pressure injury will be revealed. A deep tissue pressure injury, kind of this picture here with this, kind of almost looks like a bruise, but if any of that sloughs off, then you will be able to see the pressure area below. Patients at risk for pressure injuries. If the patient is bedfast or chairfast, if they need some or total help in moving, if they are agitated or have involuntary muscle movements, if they're exposed to moisture often, if they have poor nutrition, poor fluid balance, have lowered mental awareness, have problems sensing pain or pressure, have circulatory problems, are obese or very thin, or have a healed pressure injury, then they're going to be more at risk for that. This next slide here is going to show the most common sites for pressure injuries. So these are going to be the ones that we're looking out for as we're turning and repositioning patients, noting any redness in the skin. That beginning stage can be just like a slight redness, and we need to make sure and note that immediately to the nurse and change the patient's positioning. Pressure injuries usually occur over bony prominences or areas like elbows and so forth. These areas bear the weight in a certain position. And so according to Medicare and Medicaid services, the sacrum, is the most common site for pressure injury. So it's going to be right back here, on the back of your back, kind of going towards your bottom. This is the most common site for pressure injuries. And then the other sites include your heels, your ears, and then areas where medical equipment is attached, areas where skin has contact with skin. So you might see here in this picture, this big picture here, the heels, the sacrum, the elbows, the shoulder blades, and the back of the head when you're laying supine or flat on your back. Also, your toes could be at risk, your hip bones, your shoulders in this picture, and then side laying, these are going to be all the areas of pressure. So these pictures here on slide 13 are going to show you a Kennedy terminal ulcer, and then the first 4 to 8 hours, and then C is going to be after 8 hours of having that pressure ulcer. So as time goes on, and this is why it is so important to let someone know as soon as you see any redness or pink tinged skin in a certain area at all. Prevention and treatment of pressure ulcers. Good nursing care, cleanliness, and skin care are going to be essential. The Joint Commission and CMS require pressure injury prevention programs, and prevention is going to include identifying patients at risk, so all those risk factors, and using colored stickers or charts to identify them. Also for implementing prevention measures for those at risk, so support services, different kinds of mattresses they're going to use for them to reduce pressure on them. Also, you need to follow the patient's care plan. And then if you look to the left picture here, this is how we're going to ideally move a patient in a 24-hour period. So do you think the patient's getting much rest? Usually not. If they're moving every 2 hours like they should be, you're changing positions, then they really should not have much time on one pressure area or spot. So they start off from midnight to 2 laying supine on their back. Then we move them to their left side, then their right side, supine, left side, right side, supine. So changing their position every 2 hours is going to be essential or a have-to thing. The doctor's orders wound care products, drugs, treatment, and special equipment to promote healing. The nurse and care plan tell you what to do. Protective devices commonly used include a bed cradle, a heel and elbow protector, which are pictured here below, gel or fluid-filled pads, or cushions, and egg crate type pads, special beds, or other equipment. The nurse decides what dressings to use typically. Wet dressings are going to be used sometimes, but a dressing that absorbs drainage is going to be used if a pressure injury has drainage already. The dressing absorbs the slough, and the slough is removed when the dressing is removed. Complications from pressure injuries. Infection is going to be the most common complication, and this can even cause death. If the infection is colonized, that means that there's the presence of bacteria on the wound surface or in the wound tissue. The patient does not have signs or symptoms of an infection. Osteomyelitis can happen as well, and this is where an infection is going to get inside the bone. Inflammation of the bone or bone marrow. This is a risk if the pressure injury is over a bony prominence. The person has severe pain. Pain management is very, very important for these patients, and pain may affect movement and activity. Immobility is a risk factor for pressure injuries. It may delay healing of an existing pressure injury. Report and record any signs of skin breakdown immediately or pressure injuries at once. So these two mattresses here, the pictures of them, are going to be examples of different mattresses we can put patients that are at risk on when they arrive. So the one to the left here is called a 2-color foam cushion, and then this other bed is like an alternating pressure mattress. So it's actually very high tech. And it alternates pressure around the body, so the patients that are very at risk for this. This next slide here, slide 18, this is doing the recording of the observations of the color of the skin and any areas where you to mark and record anything that you see. Next up, we're going to move to chapter 42. There is a video with this over pressure ulcers on chapter 41, so I would prefer that you open up the lecture and go watch this video on your own on YouTube. So moving on to chapter 42 with heat and cold therapy. I think you guys probably understand this one the most. It looks like I need some light here. Heat and cold applications. Heat and cold are going to promote healing and comfort. They can also reduce tissue swelling as well. Heat and cold have the opposite effects on the body, and the risks are great. So the 3 pictures here are showing a blood vessel under normal conditions, there to the left. B is going to be dilated blood vessels, and then C, a constricted blood vessel. Before you apply heat and cold compressions or applications, make sure that your state allows you to perform this procedure, that the procedure is within your job description, that you have the necessary training, the necessary equipment, and you know how to use it correctly, and that you review the procedure with a nurse. A nurse is available to answer questions to you and supervise you at all times. With heat, it can relieve pain, it can relax muscles, it can promote healing, it can reduce tissue swelling, and decrease joint stiffness. With heat applied to the skin, the blood vessels in the area dilate or expand to open wider. The blood flow increases, tissues have more oxygen and nutrients for healing, and excessive fluid is removed after the area is faster. The skin is red and warm to touch, typically. Complications with heat applications is that too long of application can cause a burn. When heat is applied too long, the blood vessels do constrict, and the blood flow decreases. The tissue then receives less blood, and tissue damage can occur. Patients at risk for complications include older and fair-skinned patients, patients with problems sensing heat and pain, patients with metal implants, pregnant women. Make sure things that you need to do with this is report any pain, excessive redness, and blisters at once, and observe for pale skin. The nervous system damage can happen as well because of loss of consciousness, or circulatory disorders affect sensation, and as some drugs do, can cause confusion as well. Do not apply heat to an implant area. Metal conducts heat, and deep tissue, can be burned. Heat is not applied to a pregnant woman's abdomen at all. It can affect the fetal growth. Moist heat application. This is when water is going to be in contact with the skin. The water conducts heat. There is a greater and faster effects than with dry heat with wet. Heat penetrates deeper with the moist heat application. So to prevent injury, moist heat applications have lower temperatures than dry heat applications. Moist heat applications include a hot compress with a soft pad applied over a body area, a hot soak involving putting a body part into water, a sitz bath, which involves immersing the perineal area and rectal areas in warm or hot water, and a hot pack involves wrapping a body part with a wet or dry application. Dry heat applications are going to include when there is water and not in contact with the skin. The application stays at the desired temperature longer. Dry heat does not penetrate as deeply as moist heat. Dry heat needs higher temperatures to achieve the desired effect. Burns are really at risk with this as well. Some hot packs are aquathermal pads, like our Aqua K pad, which is pictured here on the right, or a K pad or and our dry heat applications, because none of that moisture is actually coming through. It's not applying wet to the patient. Even though there's water running through a machine, they're still considered a dry heat application. Cold applications are often used to treat sprains and fractures, to reduce pain, prevent swelling, and decrease circulation and bleeding. Cool the body when the fever is present as well. Cold has the opposite effect of heat. When the cold is applied to the skin, blood vessels constrict. Cold applications are useful right after an injury. Complications include pain, burns and blisters from intense cold, when dry cold is in direct contact with the skin, poor circulation, and when the cold is applied for too long. Patients at risk for complications with cold heat are going to be older and fair-skinned patients, and patients with sensory impairments and they can't feel that it's too cold for too long. Moist cold applications are going to penetrate deeper than dry ones. They are warmer than dry applications. The cold compress is a moist cold application. Dry cold applications include ice bags, ice collars, and ice gloves. And cold packs can be moist or dry applications. Applying heat and cold. So protect the patient from injury during heat and cold applications. Using cooling and warming blankets. Hypothermia is a body temperature that is much higher than the person's normal range. So hyperthermia. Okay, so above more than normal, hyper. This is greater than 103 degrees because our normal body temperature is 98.6 degrees Fahrenheit. The causes include hot weather, like a heat stroke, illness, dehydration, not being able to perspire or sweat. We should lower the patient's body temperature. The doctor is going to order ice packs applied to the head, neck, underarms, and groin. Also, cooling blankets are sometimes used alone or with ice packs. Hypothermia is going to mean that the patient has a very low body temperature or cold, less than 95 degrees Fahrenheit. Cold weather is a common cause of hypothermia. The person is warm to prevent death. Treatment may include a warming blanket, and vital signs need to be checked often. One thing with warming a patient with hypothermia is that we actually need to do it at a very slow rate versus when we're treating a patient with hyperthermia, we can pack on those ice packs and get them cool pretty quickly. But if we're treating hypothermia, we actually need to do the vital signs often, and we need to slowly warm them back up. Has been proven more effective. All right, with Chapter 42, there is also a video with hot-cold sequential devices. This is about a 3-minute video or so. You have plenty of time to watch this. Please watch this tomorrow, which is Tuesday. Oh, I was wrong. It's 5 minutes. All right, this is the end of Chapter 42, CNA lecture.